Hello dear students. Today we are going to discuss about the teratomas. Teratomas are benign or malignant germ cell tumors which are derived from pluripotent stem cells like primordial germ cells or cells from Hansen's node of primitive streak. From these pluripotent stem cells, all the three germ layers are formed, namely the ectoderm, mesoderm, and endoderm. Depending on the site, teratomas can be extragonadal or gonadal. In adults, extragonadal types of teratomas can be seen in anterior mediastinum, retroperitoneum, or pineal and suprasellar regions. However, in infants or young children, teratomas are commonly seen in the sacrococcygeal region, known as sacrococcygeal teratomas. Gonadal teratomas are seen around the second or third decade of life. They can be testicular or ovarian teratomas. For today, we discuss only about the sacrococcygeal teratomas. These are the most common type of germ cell tumors seen in utero, neonate, early infancy, or in young children. These teratomas are extremely rare in adult life. They are more common, approximately 4 times more common in females as compared to males. They are usually benign and cystic, but can be malignant, and this malignant component is usually solid, and it increases chances of malignant part increases as the age of patient increases. Histopathology. Histopathologically, a teratoma can contain mature component, immature component, or malignant component. Mature components are fully differentiated tissues like hair, bone, teeth, sebaceous gland, thyroid, pancreatic tissues. Immature tissues include the neural tubes, rosettes. A grading system depending on the percentage of the immature tissues, which is known as Gonzalez-Krusze grading system, has been established, and it divides the immature teratoma into 4 categories from 0, 1, 2, 3. The grade 0 contains the 0% of immature tissue. Grade 1 contains less than 10% of immature tissue. Grade 2 contains 10 to 50% of immature tissue. Grade 3 contains more than 50% of immature tissue. Malignant components include the yolk sac component, embryonal carcinoma, and PNETs. Malignant components usually secrete alpha fetoprotein and beta HCG. So measurement of these proteins in serum are helpful for the detection of relapse and to detect any malignant tissue in the teratoma. For sacrococcygeal teratoma, Altman or American Association of Pediatric Surgery sections classification can be used. It categorizes a sacrococcygeal teratoma into 4 types. Type 1, which contains mainly external mass. Type 2, which contains both external and internal mass. However, the external mass is usually greater than internal mass. Type 3, which contains again both external and internal masses. In this, internal mass is less than in this, external mass is less than internal mass, and internal mass reaches up to the abdomen. Type 4, contains only intrapelvic mass and no external tissues can be identified. This type 4 type of sacrococcygeal teratoma usually seen in late infancy or early childhood, and it has higher chances of malignant components. This is the clinical presentation of a external sacrococcygeal teratoma, a large mass at the distal end of a spine. For the detection of sacrococcygeal teratoma during intrauterine period, USG early prenatal checkup during early prenatal checkups is very helpful. It detects a sacrococcygeal teratoma as a solid cystic mass with calcification near the distal spine. Bladder outflow obstruction, hydronephrosis can also be seen. Rectal stenosis or atresia can also be present. A cardiomegaly secondary to the vascular shunting of and high output cardiac failure can be seen, because a teratoma can be vascular, highly vascular, so it causes the vascular shunting. All the blood goes through the teratoma, especially in solid teratomas. It is seen, and this causes the vascular shunting, and the growing fetus receives lesser amount of blood, which causes the cardiac failure. And further, this cardiac failure causes the edema in the skin and other tissues of the fetus, causes the hydrops, and anemia can also develop due to the intramural hemorrhages in the cysts of the teratomas. This also facilitates the development of hydrops in fetus. Where fetal MRI are present can be done, and these modalities of investigations are better than USG because they exactly delineate the extension, the true extension of the sacrococcygeal teratoma, and it is helpful during surgery. Differential diagnosis can be myelomeningocele, which is usually more posterior with splaying of spines, and sacrococcygeal teratoma usually presacral, so it is located anteriorly. Second differential can be chordoma. Evaluation and monitoring of this sacrococcygeal teratoma during pregnancy is very important, and measurement, it includes the measurement of the tumor size, Doppler for the vascularity of the tumor, amount of amniotic fluid, placental thickness, fetal echo. Fetal echo helpful for the detection of HOCF, placental thickness and amount of amniotic fluid. If it is polyhydramnios with increased placental thickness, it is a sign of for the hydrops. Doppler with Doppler showing increased vascularity again favors for the more malignant potential and high solid tumor with increased chances of HOCF. Larger tumor masses, especially more than 10 centimeter, have the poorer prognosis. Also look for the rapidity by which tumor increases in size. Prognostic factors include the tumor volume ratio. Tumor volume is to fetal weight ratio, which is known as TFR, tumor volume is to fetal ratio. If it is more than 0.12, then it is associated with poorer prognosis. Development of hydrops, HOCF are associated with poor prognosis. Tumor size more than 10 centimeter associated with poor prognosis. Solid tumor, more vascular tumor, more immature component, more malignant component are also associated with poorer prognosis. Management during the perinatal period includes the minimal invasive procedures to decrease the effect of sacrococcygeal teratoma on the cardiovascular system of the fetus by doing the less laser ablation and radiofrequency ablation. We occlude the blood vessels, and this occlusion of blood vessels causes the uh, lesser amount result in lesser amount of development of HOCF, decreases the chances of HOCF, and other procedures which can be used to relieve this thing, hydronephrosis. We can use bladder drainage, and to relieve the pressure symptoms on other organs, we can use cyst aspiration by a thin needle. For low risk sacrococcygeal teratomas, delivery can be done after 36 weeks of gestation by cesarean section. For high risk sacrococcygeal teratoma, a procedure known as ex utero intrapartum therapy or exit procedure can be used. I am not going into the details of this procedure. Postnatally, management of sacrococcygeal teratoma is complete resection, complete surgical resection with removal of coccyx is very important, because in case of incomplete resection, chances of recurrences are very common. If pathological examination show any malignant component, then neoadjuvant chemotherapy, preferably platinum based like cisplatin, can be used for the malignant sacrococcygeal teratomas or metastatic sacrococcygeal teratomas. Relapses are common in case of incomplete resection, immature teratomas, or malignant teratomas. So today we have learned about teratomas, especially the sacrococcygeal teratomas. These are the germ cell tumors, contain all the three germ cell layers, include ectoderm, mesoderm, endoderm, have various kinds of tissues, mature, immature, and malignant. Sacrococcygeal teratomas are classified into 4 types. Out of all the 4 types, type 1 is most common. However, prognosis does not depend on the prognosis is not very significantly different in different types of sacrococcygeal teratomas, but it mainly depends on the tumor size and the amount of hydrops, HOCF, amount of immature component or malignant tissues, and vascularity, TFR. So a complete resection, which includes initially the perinatal management with the minimal invasive surgeries, can be done, and early delivery, exit procedure can be used. Postnatally, a complete surgical resection with the removal of coccyx is the mainstay of therapy. Sometimes wait and watch can also be done, and neoadjuvant chemotherapy, platinum based, can be used for the postnatal period in the malignant tissue. If there is malignant tissue or metastatic sacrococcygeal teratomas are present, relapses can be seen. That's all about the sacrococcygeal teratomas. Thank you.